Hi everybody, and thank you for coming out again. I'm cannabis nurse Wendy Gibson-Viviani, and I was a member of the dual use task force back in 2022. And I was told that this was going to be a panel discussion, and I envisioned it as being that I was just going to sit at a table with other people from the task force and talk about the work that we did. And then I learned about a week ago that I was the only task force member who was going to be here. And so I quickly put together a slideshow for you with information that I think the task force members would want you to know. So it's not going to be a panel discussion. What I'm going to do is just show you my slideshow and then ask you if you want to participate in some discussion or if you have questions. So the task force was made up of 15 members, and we split off into 5 working groups, and those are called PIGs. That's the permitted interaction groups. So in the task force, we had members from industry, we had regulators, we had legislators, representatives from both county and state leadership. We had medical providers and patient advocates. We met monthly from April through November, and we presented our report with our recommendations for cannabis law changes in November. What we were tasked with was looking at the impacts of adult use legalization on the patients in the medical cannabis program, the doctors and nurses that certify them, also the dispensaries, and general public health and safety. We had public hearings 1 to 3 a month, and those were moderated by the Department of Health. And then we presented our report to the legislature at the end of November. 4 out of the 5 working group recommendations were adopted. The exception was the social equity group. And the reason for that was because many members felt that while this was a good start, there was more work that needed to be done. They also felt that a new working group should be formed to continue this work. And just in general, they felt that we weren't going to be able to come to a general agreement on most of the recommendations without extensive debate. So you might want to ask. So what's that?
Oh, just very familiar name.
Oh, okay.
Our Professor Garrett.
Oh, yeah. So you might ask, so what were the social equity working group's tasks? And why was this essential cornerstone piece of adult use legalization not included? Well, you can see down below. So their task was to identify the Hawaii communities and populations who were disproportionately impacted by cannabis criminalization, and also make recommendations for social equity and restorative justice, and policies that would help to reduce and remediate the past and ongoing disparities, including equity in the market, community reinvestment, and expungement of records and resentencing. And so you can see who the task force members were from there. Yeah, it was a pretty good team, I think. So while the social equity group's recommendations weren't adopted, they are still included in our report, because we wanted to have that information available to any legislators or working groups who are going to continue with the work. But what was established was that we need to include these 3 buckets in any adult use legalization laws. And these 3 buckets are cannabis justice reform, community reinvestment, and equity in the market. So the task force recommendations were that we should include the Office of Hawaiian Affairs and the Department of Hawaiian Homelands, and they should be included so that they could help determine who was going to be eligible for the social equity programs and how the lands might be used to grow and process locally grown cannabis. I was a member of the medical use PIG, and together with the Department of Health, we conducted a survey. Our task was to identify the concerns and priorities of the registered medical use patients and the certifying medical providers, and then make recommendations that would help address their concerns and priorities. So thanks to the amazing Department of Health staff and their epidemiologists, we were able to put this together pretty quickly and conduct 2 very rapid surveys to help identify these concerns and the priorities of both the patients and the providers. And the caregivers weighed in also. So the results of our survey showed that most of the patient respondents believed that the legalization of adult use would have a positive impact on the medical use of cannabis, while the certifying medical providers didn't share that opinion. But both of them commented that they thought that legalization would facilitate access for those patients who need to use medical cannabis but would not or could not or were not enrolled in the medical use program already. And they also thought that it might help reduce stigma and discrimination against medical cannabis users. So all those are good, positive, forward-looking beliefs, and I hope that they're true. So almost 90% of the respondents hoped that legalization would lead to more product variety and reduce costs. 44% were concerned that the prices would probably go up, and that's a definite possibility because of overregulation and higher taxes. So nearly 1/3 of the patients and providers were concerned that the patients were going to lose their right to grow their own cannabis. And that's a struggle that we have every so often with when legislators introduce bills that would kill the patient's right to grow their own medicine, and we stand firmly in trying to preserve that for patients. So another shared concern was that there would be less focus on patient care and that fewer patients would seek medical consultation for their treatment. Although most of the patients said that they would stay registered in the program in case Hawaii does legalize for adult use. So one of the reasons that I wanted to conduct this survey and approach the Department of Health about it was how can we assess the impact when we don't know what's happening right now as far as patients' access to their medicines? So I had that included in the survey. Was we needed to assess how well patients were accessing their medicines now. So we gathered information on what types of products that the patients needed and to the extent to which they were able to access them. Over 87% of the patients reported that they could always or often, they were able to obtain the products that they needed. But of those who were not able to get their medicines, the reasons included that the products were either not available at the dispensary, or that they were not affordable, or that they had an inability to travel inter-island. You can't bring your medicine from island to island. So patients who live on outer islands but come to Oahu for treatments can't legally bring their medicines with them. So they might be without their medicines while they're here. Other concerns were that the distance from the dispensaries and that a lack of delivery or curbside services presented access challenges for many patients. And 1/4 reported having no transportation or having a debilitating condition. And another consideration, we asked the question about whether or not the federal and state Schedule I conflict was causing any problems for them. And 3/4 of the patients reported that they weren't having any issues with employment, with traffic violations or housing, losing medical benefits, not being able to get insurance of certain sorts, or losing child custody, or being able to purchase firearms. And that was they weren't having problems with that related to their medical use or an inability to use medical cannabis in public. So for some of the patients, though, the Schedule I classification is a barrier to accessing housing and governmental assistance. The patient said that the federal law places financial burdens on patients since health insurance doesn't cover medical cannabis treatments. So lots of concerns. Most providers, though, reported that their medical practice had not been negatively impacted, but those who had been impacted said that the law interfered with their ability to provide patient care. Or it's what caused the patients to be hesitant to enroll in the medical cannabis program. The survey also asked patients which medical information sources they relied on. And 2/3 said that they consulted with their healthcare professionals, but a large proportion, like 56%, said that they also obtained information from the dispensary workers. So we came up with a couple of lists of recommendations. And the first one is that we should allow terminally ill patients to use their medical cannabis in healthcare settings, so hospitals and hospice care. And we did get a bill out of that. We also talked about getting some higher THC content per serving, per package to be allowed for medical use products, and that the dispensary set aside some specific products for patients. Because in other states, when they start up adult use programs, the patients suffer because the store runs out of cannabis, and so the patients are kind of left in the lurch. There's no consistent supply of medicine. We also suggested that the dispensaries be able to provide delivery services and curbside pickup. And we also suggested that the state eliminate the list of qualifying conditions so that that would leave it up to the doctors and nurses who do the certifying to decide which patients were appropriate to use medical cannabis, rather than having to go by a pretty restrictive list. We also maintain that patients should retain the right to grow their own medicine. We wanted to make sure that medical cannabis patients would be exempt from any new taxes from the sales. Here's number 8, the dedicated inventory. And then 9, that all existing medical cannabis licensees, so the dispensaries, be allowed to continue to operate without disruption as the adult use program is operationalized. And we saw that as a way of helping maintain a consistent supply for the patients while the adult use program is being rolled out. We also thought that the legislators should try to provide some employee protections so that employees can't be fired from their jobs just from having a positive test. And just having a positive test is not proof of impairment on the job. And also, firearms. The law enforcement agencies shouldn't be denying or revoking the right of people to own firearms. So another recommendation that I helped work on was to try to bring more medical cannabis education to Hawaii and to doctors and nurses specifically. And so what this recommendation says is that any doctor or nurse who wants to do the certification, issue the 329 cards to patients, should have at least 2 contact hours of medical cannabis education before they can get started doing that. We also suggested that the School of Nursing offers some medical cannabis education as part of its curriculum, but we can't really legislate that. So In order for them to qualify to do the certifications, they would have to complete a minimum of 2 hours of evidence-based medical cannabis education. And they could do that by either viewing some training videos that the Department of Health created or purchase some of the continuing education programs that I've got information for at my booth. And some of those are the official providers for different states already that require medical cannabis training for their doctors. So, some additional recommendations that we made also, that we should have a working group that should look at these conflicts of federal and state laws that are causing so many problems. And that we should maybe try to find some better potential solutions. And Dr. Cliff Otto has been a champion in trying to get an exemption from the DEA, just as the Native American Church has done for peyote, to just get off of the Schedule I drug classification. And he did actually get a resolution passed on that, but there's been no action taken on it. But we wanted that to be included in these discussions in the working group. So there are a couple of bills in motion. One was heard yesterday, and another one's going to be heard on Monday. And this is so that terminally ill patients can use their non-smoked medicines in certain healthcare settings. And this was passed in California in 2021, and it's known as Ryan's Law. And Ryan was a 41-year-old son, dad, who developed a terminal cancer. And he was placed in a hospital in California and was denied his medications. He had been using cannabis for pain management and stress management. And possibly for nausea also. But anyway, the hospital said, no, you can't use it here. And so Ryan's dad, Jim, he had to find a hospital that would allow Ryan to use his medicine. And he found one in the state of Washington. So he had to fly his son, his very sick son, over to Washington State so that he could live out the rest of his life not stoned on opiates and other medications. So those are two bills that Ryan's dad, Jim, called me because I'm a member of the Cannabis Nurses Network, and they were instrumental in helping pass this in California. And they're trying to get it passed in 15 states right now. So I'm the Hawaii team leader, trying to get these bills passed. So we also have bills in motion for curbside pickup, some for employment protections. The Grow Your Own is going to limit the properties to 5 cards per site, which is going to be really problematic for the collective growers who have hundreds and hundreds of patients growing on the property. Right now we only have a 1-to-1. Each patient can only have 1 caregiver. And this bill suggests that maybe the patient could have 2 caregivers, but that these caregivers couldn't themselves be users or be paid with cannabis. And then this bill also adds the ability to transport your medicine by air or by sea, which right now is federal space. So that's the reason you can't bring it. Then there's also a bill that would allow dispensaries to sell cuttings. And, Ryan's Law Action Center on the Cannabis Nurses Network, they have a facility guide to help the hospitals implement this. And I think I'm pretty much at the end of that. I think that there aren't any other bills that were the result of our recommendations. Except for a waiting room. One of the barriers to access for patients at the dispensaries was that if you're a parent and you drive over to the dispensary, there's no place to put your kids. So they're not allowed in the dispensary. So you can't leave your infant in the car. So they're talking about the definitions of waiting rooms and creating special waiting rooms so that more people can come in to the dispensaries. And that's pretty much it. I'd like to ask you to help me fight for these two bills that would allow the terminally ill patients to to use their medicines, non-smoke medicines. And that's pretty much it. Thank you very much. Does anyone have questions? Yeah.
I just want to comment that my patients have just had someone bring it to them at bedside, and it's just not known to the medical staff.
Mm-hmm.
But that's not necessarily how we want to do it. But a lot of the medical staff aren't educated anyways, so.
Yeah, well, the medical staff can't administer.
I know, but I mean.
So she's saying that the hospitals kind of just turn a blind eye, and yes, that's true. I called a few of the hospitals just to ask them, what is your policy on this? And they don't call me back, and or avoid the question. I don't know that they really have a policy against it, but I have seen a couple of hospitals make accommodations for patients and just said, if I don't see you doing it, I don't know you're doing it, and so they had the family take the patient out of the room and onto a lanai or something so that they could use their medicine. And this was an issue with passing Ryan's Law in California. The hospital said, if we allow you to bring a Schedule I drug here, we're going to lose some of our federal funding, and so we can't allow it. And so the bill went through in California and passed in 2020, and the governor vetoed it because the hospitals were yelling about it. So they reintroduced the bill again after one of the senators contacted I can't remember, like the Department of Health and Human Services or somebody, whoever regulates this, whoever would be the person to tell the hospital that they couldn't use it. And they said, we haven't actually developed any policies and procedures yet, and it hasn't happened, and it wouldn't be us who would be the problem. That it would be if the Department of Justice decides to interfere with the medical program. So that's why it passed the second go-round, was because they were able to, they got a letter from the federal department saying, no, we're not going to come in and ding you for this. We're not going to take away your federal funding. But so as it stands right now, though, you have to have somebody in the hospital or whatever healthcare setting that the person is in to administer it. You have to have a caregiver there. Because the staff can't administer it. What they can do is lock it up, bring it to you. They can document that you took your medicine, and they can help other ways, but just not administering it. Any other questions? Yes.
I've got two. The first one is, so you said that there were 5 working groups?
Yes.
Social equity and the medical marijuana.
Uh-huh.
And then what were the other 3?
Taxation. Let me go back to. Huh. Well, this is just the 2. That's not it. I might have. taking it out of here.
No, it was the third slide.
Oh, was it?
Yeah.
Oh.
It's at the front.
Okay. This one?
Oh, was it? Oh, no.
Yeah, that's not a list of them. There is a whole list of them, but you can look online. Our whole the whole every meeting is online. You can watch the videos. You can and then our report too. Yeah, it has a list. So we had market structure, taxation. What's the third one? Okay. Medical, state and county. I'm sorry, I can't remember the fifth one. Can you look it up?
Yeah, market structure investigation.
Market structure, taxation.
Public health and safety.
Oh, public health and safety, of course, yes. Yeah, that was a really good group. Yes.
Do you think any of these bills will make it into law this year? And if they do you think they'll be signed by the new governor into law?
The question is, do I think any of these bills will become law, and will the governor sign them? And yes, I think we have a good chance at getting some laws passed. Are you talking about legalization?
I'm talking about the laws that you just listed.
These, yes. I think that the one for the terminally ill patients has a pretty good chance. At the hearing yesterday, there was no objection from the Department of Health. The law enforcement, of course, has concerns, but they didn't vote against it. Yesterday's hearing, I can't remember how many cannabis bills they heard, just back to back to back, but it was kind of all day. And they didn't come to any conclusions. They didn't vote on it. This was just for discussion. So it's been deferred. However, so I went down to the state capitol on opening day, and I had my my hemp pack with the cannabis leaf on it. I had my American Cannabis Nurses Association mask with the big leaf on it. And I was sitting outside of Governor Green's office making my next packet for the next legislator that I was going to talk to about Ryan's Law. And Governor came out, he looks over at me and he says, "Whatever it is, I'll sign it." I was like, okay.
Here's the legalization bill.
Okay. Well, he has said that if we pass legalization, he will sign it. He has said that, yes. So I'm hopeful.
And as a follow-up, can I just do one quick follow-up?
Yep.
As the cannabis community, what can we do to help you get those bills passed?
Cannabis community, what can you do to help us get those bills passed? You can go to the legislative website and register, and then sign up for hearing notices. So when the hearings are scheduled, you'll get a notice and you can submit testimony. That would be the absolute best. And I suggest that you go in and read some of the testimony that's already been submitted for ideas on what you want to write. Yes, that would be most helpful, yes.
So if there is legalization, are you looking at restricting us that are already medical patients being able to grow then? Because I filled out that survey when it came
Oh,
around.
good. Well, thank you for that. That was
one of my fears when I started reading through the questions and they were with questions on that.
Yeah, I don't know. I'm pretty sure that patients are, well, we were kind of warned by Dr. Sue Sisley, who said we need to get this in law, in perpetuity. We need to get the patient's right to grow their own in perpetuity, somehow.
Yeah, because me as a patient, I like to grow my own because I
Sure.
feel like I'm part of the process. I grow what I want, and I grow all natural. I know
Sure.
nothing bad's going into
Mhm.
it.
Yeah, it's very, the best medicines, and growing is therapy itself, too.
It is, yeah.
Yeah. And no, I will fight for the right for patients to be able to grow their own. as fiercely as I can and hope that, yeah, my best is good enough. Yes?
Didn't the adult use bill that they were working on also include, I believe, individuals could grow up to 10 plants?
Yes, the adult use legalization bill, the recommendation was for 20 plants per person with no limits per household. And so I kind of objected to that. I don't think that people who are using it, yeah, just for their own, growth, they really need 20 plants. And then, yeah.
The only thing I could disagree with that on is because when you grow,
Yeah.
I've been growing now with my medical license for about 7 years now.
Okay.
And you'll get 60% will be male.
Oh.
So, like, and
Okay.
40% will be female.
So to ensure that you get female
Yeah,
plants.
that I have enough
Yeah.
medicine to last me
Sure.
for a year once I harvest.
Okay.
So you might put 20 plants in, but out of that.
You don't
only
get
have
20
six-
plants
you'll have
out of-
6 female out
Sure,
of it.
sure.
And the rest are just going to chop and throw away,
Yeah.
after they're,
Well,
once the
and-
sex-
Yeah, and also patients who want to juice, need probably, a larger number of plants than 10 anyway, too. So maybe 20 is okay. I don't know.
But, that would be my argument on, because a lot of it you combine and throw away once you figure out it's male. Chop it down.
Okay, so just attrition. Yeah, yes.
What I found this year, and I'm not sure if it's just the county of Hawaii, but anybody that's had the sheriff, it's the sheriff department, they are the ones that do the gun laws,
Uh-huh.
and they've actually gone and said you can't, and I don't know where their information came, but they.
So law enforcement is,
Sheriff, for a gun permit, it's through the
Yeah.
sheriff department.
okay,
And I know it's the county of Hawaii, and I don't know how the other islands are, but I've had patients and they're forced to say either I surrender my marijuana certificate or I get my gun permit.
yeah, it's a real problem. Patients are being denied gun permits and have to show that they have been off of the marijuana for a year.
Here, I know.
And that, there's something, just basically wrong with that.
Is that the whole state or is that?
That's federal.
No, but
What?
the county, the firearm county.
Well,
The
it's
fire-
license here, but-
Yeah, it's a federal law. They have to honor it. They can't find workarounds for federal law. Yeah. Yes.
Do you know of any organizations that are tracking all of the cannabis legislation?
The only groups I'm aware of that are tracking all the legislation is Marijuana Moment and maybe MMP, or is it, Marijuana Policy Project, MPP. Yeah, but the Marijuana Moment, Tom Angel, I think his name is. Yeah, he tracks all the legislation in all the states.
Marijuana Moment.
Marijuana Moment. What did I say?
No, I don't, that's what you said.
Oh, okay.
Yeah.
Yeah, Marijuana Moment. Check for that. Yes.
So one thing I've noticed, I'm sure it comes up, and you brought it up briefly, but for medical marijuana patients going to dispensaries, the prices are absurd.
Yep.
What you have is then people choosing not to reapply for their card when it expires, and then bringing it from the state, and then of course going to our community and finding, street sellers who have much more reasonable prices.
Mm-hmm.
So what recommendations out of your working group do you have for not making it so cost expensive? And,
Okay. So the question was related to the prices at dispensaries, because, it's going to be the
country.
adult use shops. Yeah, they're going to be high, and they're going to be higher than the illegal grows or the gray market, they call it. And that's, we know it's a problem, and we have to try to keep the prices lower than the black market. And that's just not easy to do when you're over-regulated. And so no, we definitely, check out the recommendations from the tax department and the market structure. working groups, because they address that.
I mean, $80 for an eighth is absurd, and it encourages people to, even go to other states.
Mm-hmm.
Spend that additional cost to go to Arizona or to go to New Mexico, where it is significantly cheaper, and they do have a lot of regulations there on cannabis as well. But what is it about the state of Hawaii that similar structure, moving from medical to a dual use scheme? What is it about this state that
California
that-
hundreds of mountains.
Well,
what is it about this state? Because
it's high.
the first
It's
state
high.
with medical.
Our regulations are more intense. They're more highly regulated. They have more
In what way?
expenses. Seed to sale tracking systems, security. They can't. Well, everything has to be done in cash. So they have to hire like armored trucks and have an armed person aboard. I mean, it's just. I mean, the expenses are just endless. But knowing that, so the market structure and the tax working groups looked at that and said, well, how can we try to help them keep their prices lower? And they started off with like just minimal taxing on it. And, and maybe increasing the taxes over time or not, allowing them to be able to grow, just look at how much they needed to grow, maybe reducing the burden on them for certain costs. I don't know. I mean, there's the lab testing's expensive. Just so many areas that you can try to work on. But yeah. Anyway, I don't remember exactly what the recommendations were from the market structure group, but I'm pretty sure they addressed it pretty well. Yeah. Yes.
I have a quick question. In the discussions, was there any discussion of opening up more dispensary licenses for Hawaii?
Oh. So the question was there any discussion about opening up more licenses for dispensaries? And no, not necessarily. But we wanted to increase the existing licensees' capacity to grow more and to sell more too. So I don't know that there was any specific recommendation made for that. Yes, in the back.
Do you think there'll be a point in time where like local farmers or growers could feature things or products in a dispensary to lower the costs?
Question is whether or not the small farmers might be able to have their products for sale in the dispensaries. And yes, that was a topic of great discussion. How do we promote our small farmers and not let a big corporation come in and take over everything? However, that's exactly what's happening in every other state, and we did our best to try to figure out how do you keep that from happening. And there isn't any real good way to tell them that to impede commerce. That's the problem. You can't impede commerce. But we did try to, the social equity working group addressed that really well also, in looking at how do we promote the small farmers and allow them to sell their products.
Or if they follow the rules of a dispensary grow from seed to sell, pretty much like tag them, test them.
Yeah. Well, the market structure group looked at that and said, how maybe we can come up with a different set of licenses. If you want to just grow a small amount, then you're just licensed to grow a small amount. Yeah. Sure. And then I think you would only be able to sell it to, I don't know, somebody, yeah. But I don't know if dispensaries would buy it or not.
Because I feel like they're having a hard time keeping up if it turns recreational.
Uh-huh.
The flower.
Yeah.
Concentrates and making all the products.
Yeah, they probably will have a hard time keeping up with production. And so, yeah, so we looked at that and said, we need to allow the dispensaries to grow up and also maybe, start getting some other growers to, maybe a different license type. Yes,
This is an offshoot. But
that's okay. Go for
are you
it.
looking at anything on decriminalizing nature with plant medicines or psychedelic medicines, psychiatry?
Oh, you're asking about decriminalize nature and using psychedelics in treatment?
Are we going to be way behind?
Oh.
Here in
Oh,
Hawaii?
we're way behind. We're way behind. There is a psilocybin bill, but yeah, I mean it's looking really good for psilocybin in other states.
But that would be great here in Hawaii, especially for the medical community.
Well, get involved. You know, there's a bill in motion right now. Yeah, go weigh in on it. Tell them. Yeah. Any other questions or? Yes.
Is there a big fight in federally to get it not a substance for narcotic? Is that going on? Because then
It's
it
going
becomes,
to free, they're saying.
Well.
because if it comes under as a herb,
Uh-huh.
FDA doesn't have any say.
Sure.
We buy all kinds of supplements, natural supplements.
Mhm.
Why couldn't marijuana be a supplement rather than?
Okay. So the question is there some work going on a federal level to get cannabis out of a Schedule I drug category, and also to what was the other part?
Well, because if it's not a Schedule I.
Yes, if it's not a Schedule I, it can be herb. Hey, why don't you come on up here? This is Amy. She.
I can answer that, yes. That's
Yes.
exactly my wheelhouse, yes.
She's an herbalist, she's a nutritionist, and a cannabis researcher. And, yeah, because, yes.
Hi, so my name is Amy Robertson Nielsen. I am, as Wendy was so very nice to say, I am a doctoral candidate in clinical nutrition, actually, and my doctoral study is in long-term cannabis use and metabolic syndrome. I have been not part of, but been watching and very involved with the dual use task force over the last year, and was very involved with listening and watching for Wendy yesterday as she was doing all this other stuff to help her understand what was going on at the task force at the hearings yesterday. So to answer your question on if this becomes descheduled, can we then regulate this as an herbal supplement? And the answer is probably that's what's going to happen, yes. Okay, now, that said, the cannabis industry also understand that there are huge laws that they're going to have to understand. The SHEA is one that regulates the herbal supplements and all of the manufacturing and all of our CGMPs and everything, our grow sites and everything like that. That's already in progress. It's already under regulation under the FDA. So there are already rules and regulations that the cannabis industry, if we become descheduled and if we go under the herbal supplement industry, they're going to have to shift to a whole other system of regulatory understanding that will shift all of their paperwork, that will shift all of their all of that. It's a big process. We in the herbal industry, I'm an herbalist, I'm not a registered herbalist yet, I'm working on that with the American Herbalist Guild. But we who are herbal product workers right now, the American Herbal Products Industry Association has a lot of guidelines on CGMPs that you can look at in the cannabis industry now if you're interested in finding out if we do get descheduled. And if we do become part of the herbal supplement industry, you should probably start reading that information now. Thanks, Wendy.
Great. Thank you, Amy.
Can I say something about that? On January 23rd, Dr. Janet Woodcock at the FDA, she does a lot of their
Can I have you
directors.
talk into this? Oops, it's only going to reach here.
So on January 23rd, one of the directors of the FDA, Dr. Janet Woodcock, released a letter saying that the FDA is not going to regulate CBD-derived dietary supplements.
Yes.
And this announcement was a result of advocates and physicians, et cetera, going and pleading to the FDA, hey, is this something you could possibly do? The FDA said no. because there's no way to conduct the research because it is Schedule 1. So right now there's a huge window of opportunity for policymakers and regular citizens to go and plead to Congress to work towards descheduling, because there is this huge public health issue that these cannabis derivatives are being widely used because now it's recreational, and there is, there's no way, I'm originally from Arizona, and anybody and everybody can get as much cannabis as they want without any kind of, stop and halt and like, is that actually, that quantity, is this safe for you to use? The research is not there. And so I think this year what you will see is a greater push towards our federal legislators to look at the Controlled Substances Act and see if there is a way to decriminalize. Because in last year, President Joe Biden, he did his whole task force to figure out what the federal government can do besides just say, oh, if you're incarcerated under federal law for a weed crime, you're one of the 1,500 people, okay, you can go free now. Descheduling can't happen from the executive branch. It has to come from Congress, because Congress determines what admin agencies like the FDA can do. So,
Great,
that's my
thank you
2
so
cents.
much.
There is a recent bill though, I saw from 1 to 3.
Great.
So there is information. There is a recent bill that just went into effect in, I believe it was December. It's either December or January, that has changed how we can research cannabis. That's a huge step towards decriminalization. Towards descheduling, and we can't do descheduling until we have the peer-reviewed evidence. And as a PhD researcher, that's exactly what I'm doing. Thank you very much. So yes, so as we get that research out. Now, the caveat with that research bill, that research information is that that is NIH funded, so little grassroots researchers like me can't get that funding yet. So, however, what you can do is you can support researchers like me doing case studies. So if you have a doctor who you want to, who you were working with, who is a cannabis-friendly doctor, and you want to have your case study published because you are having good results from your medicine, the only way that we can get peer-reviewed evidence into the higher up is if we have case studies. Every research trial is based on case studies. So the more case studies we have, the more weight we have towards saying this is a possibility for research. So talk to your doctors about getting researchers involved in your cannabis use and in your cannabis medicine.
She has a question.
Yeah, go ahead. Question.
I can talk to you later.
Okay. Question later.
And that's kind of a question.
Sure.
What you're saying your research is on is, has there been anything found long-term use of cannabis that will harm you physically?
The answer is yes. The question is are there long-term use of cannabis that can harm you physically? And the answer is yes. There are certain populations for whom cannabis is probably not the best option. There is peer-reviewed evidence that shows, and this is not just mice, and this is not just observational studies. This is randomized controlled trials with whole smoked cannabis that show that people with schizophrenia and certain psychoses probably shouldn't be smoking cannabis, or if they are, they should be working with somebody who they can work with on very specific strains and chemovars that are appropriate for them. There is also research that shows that people with certain autoimmune diseases shouldn't be taking cannabis because it can exacerbate a low TH1, TH2 function. So if you are an epidemiologist, you understand what that means. But that means that if you have a particular type of inflammatory response, then it's probably not the best thing for you because it increases that response. For the rest of the population, that's a good thing. But for their very small populations, there are people that it's not for. Yes, absolutely.
And there are people who are allergic to it.
There are absolutely people that are allergic. And there are now there's now new studies that are coming out that there are genetic mutations and genetic modifications that show that there are people that are hypermetabolizers that probably are going to get hyperemesis, which is when you vomit uncontrollably after a certain amount of cannabis, and those people also probably shouldn't have cannabis.
My main thing, because I've been using for, if there's going to be a long, an implication, like I might get something.
Oh.
like
No,
green
no,
card,
so-
I've been reading
No,
about.
so my particular research in long-term use cannabis and metabolic syndrome is specifically on cardiovascular disease, hypertension, and lipedema. So, and that's what determines cardiometabolic disease. So, and what I'm in the process of writing that research study. My literature review, the stuff that I've reviewed in peer review says that it's going to hopefully, when my study comes out, show that it is helpful for that, for cardiometabolic syndrome. But again, I'm in the very beginning research stages of that. I've only done the literature review, and I'm in the process of writing the study for that. Any other
Any more?
questions?
But opioids are great for you.
So here's the thing. So, okay, I'm going to jump on my little soapbox here for 2 seconds. So she said opioids, and opioids are my favorite topic because, okay, a little bit of personal information here. I am a former opioid addict, and the reason that I am no longer is because I smoke cannabis, okay? And this is actually a big basis for my research, my impetus for research in this, because I got pregnant and then realized that I couldn't take opioids anymore. And needed to switch to something else. And as a teenager, and I was 38 at that point, and as a teenager, I had smoked cannabis, and for my other diseases, figured out that worked for me, and I said, hey, this seems to be something that I can go back to and does a little bit for me. In my research now, as a doctoral student, I have discovered that there are many parts of the cannabis plant, many constituents in cannabis that do act on opioid receptors, your serotonin receptors and things like that, that really do impact your ability to metabolize your opioids. So if you take opioids, it's going to increase your opioid, the effect of your opioids. And 2, if you do take opioids and you're trying to get off them, it's a way to wean yourself off of them. So I'm living proof of that. There is research for that. I'm happy to give you that research if you'd like.
Hey,
But it's incredible how
right in front of your- there you go.
opioids are the drug of choice when cannabis, like you just described, doesn't have that kind of long-term effect, is illegal.
Yes, exactly. So the illegality of cannabis versus the legality of opioids is a whole other landed topic we can be talking about, and that's a whole other ball of wax. But to that end, because of the research that's coming out, because of the research that's being, it's all observational at this point, because we just got the green light to be able to do real research. But because of this observational research, there are many states that are now using their cannabis programs as a way to mitigate their opioid disasters.
Great.
Any other questions?
No.
Thank you, Wendy, so much.
Thank
I
you so
appreciate
much.
it.
Likewise. Oops. Thank you, everybody, for coming in. I really appreciate all your great questions.